Okay, so thank you very much for the kind introduction, and thank you very much for inviting me here to this meeting in Abu Dhabi. Unfortunately, I'm here in the near the city of Amsterdam in the Netherlands, so I couldn't join you there on location. So today I've been asked to discuss the role of hydrocortisone as a treatment in the prevention of BPD. I would first like to disclose to you that I've received financial support from the companies listed here. So this is the outline of my talk. I'm going to very briefly touch on the rationale for using steroids when we talk about BPD. We're going to ask the questions, why do we need a new steroid? Because we all have been using dexamethasone for a very long time. And then finally, hopefully answer the question, does hydrocortisone actually work in preventing BPD, and is it safe? And then some conclusions at the end. So what's the rationale for using steroids when we talk about BPD? Well, I guess you all know that bronchopulmonary dysplasia is a multifactorial disease, as shown here in this slide. But it's been shown by numerous studies that an inflammatory response, being either antenatal or postnatal, is an important risk factor for developing BPD. And we've learned from many other diseases that if you have inflammation as part of the pathophysiology of a disease, that steroids can actually have a benefit. So there has been some studies looking at if steroids actually can dampen the inflammation, because this is what you would expect. And this is a study done in the early 90s, where they took some tracheal aspirates from preterm infants at risk for BPD. And then they took these aspirates before and after these infants were treated with corticosteroids. And you can clearly see that the mediators that have been tested in this study clearly were dampened after the use of steroids. So steroids could play an important role in preventing BPD by dampening the inflammation. So the question is, why do we need a new steroids? Because like I mentioned in my introduction, we've been using dexamethasone for a very long time. And there's good evidence from placebo-controlled trials. Dexamethasone actually is very potent in reducing BPD. What you can see here is the meta-analysis of all the studies that have compared dexamethasone to placebo, started after the first week of life. And this is what we call targeted ventilation. You already have a patient that is at an increased risk of developing BPD, and you want to target that specific patient with dexamethasone. You can see here on the left side of the slide the outcome of interest and the number of babies that were randomized in the different trials. You can see the relative risk in the middle, and then you have the forest plot on the right, where the white diamond is the treatment effect and the yellow bar is the 95% confidence interval. And if it doesn't cross the one line, this confidence interval, we will have a significant difference. So what this meta-analysis clearly showed from the studies comparing dexamethasone to placebo is that dexamethasone is a very potent drug in reducing BPD, as you can see on the slide, with a number needed to treat of only 6. However, we've learned from other studies that if you treat patients with steroids, that you usually get some adverse effects. And in terms of the preterm infants treated with dexamethasone, these are mostly hyperglycemia and hypertension, as shown here. Interesting, just to mention, is that if you look at long-term outcome, and there were only a limited number of trials that actually did long-term follow-up, but you can see that when you use dexamethasone as a targeted treatment for high-risk patients, there is actually no sign from these studies that there's an increased risk of adverse neurodevelopmental outcome. So once it became clear that dexamethasone is very potent to reduce BPD, people started wondering, what if we would give it sooner? What if we would treat babies before the first week of life? And this would probably be defined as sort of a prophylactic treatment. You don't really know if this baby will actually end up on a ventilator and have a higher risk, but you just assume that a baby is at a high risk at the time of birth, and within the first few days after birth, you will start treating these babies with dexamethasone. Again, you can see that if you use dexamethasone in a prophylactic way, so in the first week of life, it will give you a reduction of BPD. But in contrast to the theory, it doesn't seem to be more potent and in terms of the number needed to treat, because it's almost doubled since compared to the trials that actually use dexamethasone as a targeted treatment. And more importantly, if you look at adverse effects of dexamethasone treatment, you can see that in addition to hypoglycemia and hypertension, we now see also problems in terms of gastrointestinal perforation and bleeding. And finally, and most importantly, studies that looked at follow-up showed an increased risk of the outcome death or cerebral palsy. So these were concerning results, especially for prophylactic treatment. And as a result of these studies, the American Academy of Pediatrics issued a statement in 2002 stating that the dexamethasone is no longer recommended for the prevention or treatment of BPD in infants with a low birth weights. So what happened after this statement? Well, first of all, and as you could show here, is that clinicians started to use less dexamethasone or steroids altogether. This is an interesting study by Joder, where he compared 3 epochs, one before, one during, and one after the APA statement. And you can see here with a breakdown in gestational age from 24 weeks up to 28 weeks on the x-axis. In the gray bars, you can see the use of dexamethasone over time in these different gestational age bins. And it's clear to see by the gray bars that over time there is a significant drop in the use of dexamethasone in these babies. Interestingly, if you look at the BPD rate indicated in black bars, you can see that there's an opposite trend, where with less use of dexamethasone, there is an increase in BPD rate, which I guess is logical if you look at the effects of dexamethasone on BPD in the randomized controlled trials. So the first change after the APA statement was people are using less dexamethasone. The second thing that changed is that people were postponing dexamethasone in those babies that needed to be treated. And this is a study where they looked at when would clinicians consider using dexamethasone if a baby was on a ventilator. And you can see that most of the clinicians actually started to use dexamethasone if babies could not be extubated after 5 to 6 weeks of life. So in addition to less treatment, there's also late treatment of these babies. The next thing that happened is that people also started to use a lower dose of dexamethasone. And I guess you're all familiar with the DART trial, which is a study that actually investigated the effect of a much lower dose of dexamethasone that was usually used in the other placebo-controlled trials. So the DART protocol, which is used across many centers around the world, uses a very low cumulative dose of 0.89 milligrams per kilo divided over 10 days. The treatment started in this trial in babies that were more than 3 weeks old. And although they intended a sample size of 814 babies, this trial was stopped early because of lack of recruitments, and the final results were based on 35 infants in both groups only. In addition, a large proportion of the babies actually received a second dose in a late rescue treatment with steroids. And the bottom line of this trial was that dexamethasone did improve lung function, allowing babies to get off the ventilator, But in contrast to the earlier studies on dexamethasone, there was no difference whatsoever in BPD. So I think it's important to realize that many of us are using a low dose now based on a very small study which showed no effect of this low dose on BPD. And finally, what happened is that people started to use hydrocortisone. This is a study, a survey study published where clinicians were asked, what kind of steroid do you use in your unit? And you can see that already a third of the babies in this study were treated with hydrocortisone and not with dexamethasone. You can see that most of the clinicians use targeted treatment, so babies at high risk, usually after the first week of life. And it's interesting because the actual evidence at the time this study was done on if hydrocortisone is effective in reducing BPD and is safe is actually quite limited. Why would hydrocortisone have a better profile in terms of benefit and harms than dexamethasone? Well, first of all, it clearly targets different receptors than compared to dexamethasone. There has been some animal data suggesting that hydrocortisone has less adverse effects on the brain, especially the hippocampus. And there have been cohort studies of centers that have used hydrocortisone for many years, and one of these centers is located also in the Netherlands. And these cohort studies suggest that hydrocortisone improves lung function and has no real adverse effect, especially on the long term. So there was a clear rationale and a need to do some studies on the effect of hydrocortisone in preterm infants at risk of BPD. So, does hydrocortisone actually work, and is it safe? So the first studies that actually looked at hydrocortisone were studies that looked at prophylactic treatment, very similar to what I showed you for dexamethasone. So these are studies that used hydrocortisone early on after birth in all babies, depending on certain patient characteristics. And this is the meta-analysis of the trials that have been done so far, comparing hydrocortisone to placebo. And what you can see is that if you look at mortality and BPD, the first two lines, for these separate components, there is actually no effect of hydrocortisone on these outcomes. So there doesn't seem to be a benefit in terms of BPD. If you combine death or BPD, you can see there is a borderline significant reduction in favor of hydrocortisone, and the number needed to treat is about 17 to 18. If you look at failure to extubate on the fourth line at day 7, you do see that there seems to be a short-term benefit of hydrocortisone in terms of weaning babies off a ventilator. In terms of adverse effects, you can see there's an increase in gastrointestinal perforation in the babies that were treated with hydrocortisone, and it doesn't seem to be any negative effect in terms of death or cerebral palsy when you use hydrocortisone in this population. I just want to have a closer look at one of the larger studies, and the more recent studies on prophylactic hydrocortisone treatment for BPD, and this is the Premiloc study that was conducted in France. So this study included babies with a gestational age between 24 and 28 weeks, and these babies needed to be less than 24 hours after birth. The intervention was hydrocortisone in a low dose, cumulative dose of 8.5 milligrams per kilogram, delivered over 10 days. The comparison group received a placebo, and the primary outcome of interest was death or BPD, determined at 36 weeks postmenstrual age. This Premiloc study included 523 babies. You can see here the median gestational age, 26 weeks, almost 27 weeks. And you can also see that if you look at the babies below 26 weeks, there was only a third in this population. Interesting also, and I'm going to come back to that in a minute, is that if you look at the number of babies that were intubated at the time of randomization, and remember, randomization was done within the first day after birth, 80% of these infants had an endotracheal tube and was on mechanical ventilation. Also important to realize that recruitment was stopped early in this trial. So what were the results of the PREMOLUX study? You can see here that if you look at the combined outcome, very similar to the meta-analysis, you can see there's a borderline significant reduction in death or BPD at 36 weeks in favor of the babies that were treated with hydrocortisone, and the number needed to treat was 12. So you need to treat 12 babies to get one less baby with death or BPD. But again, you can see that if you look at the two components of the combined outcome, mortality and BPD, there is no significant reduction in favor of the hydrocortisone group. What about adverse effects in the PREMOLUX trial? Again, these were pretty reassuring if you look at the long-term follow-up, so at 2 years corrected age. No difference in terms of cerebral palsy or major neurosensory disability. Now, I think it's really important that if you read a study and you want to see if these results would also be applicable to your situation, it is very important that you'd ask yourself the question, is the study population similar to the infants that I treat in my unit? And this is exactly what I did. I looked at the population, the PREMOLUX trial, and compared this to what we do in Amsterdam. Now, I mentioned to you that 80% of the babies between 24 and 28 weeks in the PREMOLUX trial were intubated at the time of birth. In Amsterdam, we have a pretty aggressive, non-invasive approach, and you can see here the number of babies that were intubated in the first 3 days of life in Amsterdam from 2014 to 2020, and you can see that in 2020, less than 5% of all the babies between 24 and 30 weeks in Amsterdam are intubated within the first 72 hours after birth, which is significantly and hugely different to what has been shown for the PREMOLUX trial. If you look at the number of babies in the first 10 days of life that are not intubated and invasively ventilated, you can see the PREMOLUX study in blue and the Amsterdam population in red. And you can see that actually within 24 hours of life, most of the babies in Amsterdam, if they were intubated, were already extubated to non-invasive support. While in the PREMOLUX trial, more than half of the babies in the placebo arm remained on mechanical ventilation for at least 10 days of life. So you wonder, have these babies in Amsterdam and in France the same risk of BPD? And I guess this is not the case. And to support this, I'm going to show you here a nice study done by the Italian network, where they looked at the risk factors in a large cohort and national cohort of preterm infants, the risk factors for developing bronchopulmonary dysplasia. And as expected, ventilation was an important risk factor for developing BPD. But they also showed a breakdown in terms of the duration of mechanical ventilation. And as you can clearly see, if you are invasively ventilated for less than a day, you do not have an increased odds of developing BPD. If you are ventilated for a day to 7 days, the odds are 2.4. And especially if you're ventilated for more than 7 days, your odds significantly increase, in this case, up to 15. So I think that this is really important for you to look at your own situation. I think that in Amsterdam, we do not intubate that many babies in the first 3 days of life, and most babies are actually ventilated less than 24 hours, which means that the a priori risk of developing BPD in Amsterdam is probably much lower than in France, in those centers that were including babies in the Primulog trial. And I'm wondering if the effect of hydrocortisone will be similar in Amsterdam as compared to France. And I think that we think that it's not the same, and because we have patients with different risk profiles. So what about targeted hydrocortisone treatment? So treating babies after 7 days of life, those babies that you actually know have an increased risk of BPD because they're usually still on a mechanical ventilator. So we did a large study in the Netherlands and Belgium, and this study looked at the use of hydrocortisone to reduce BPD after 7 days of life. This was a StopPPD trial. So we included babies between 24 and 30 weeks that were invasively ventilated at some point in time between 7 and 14 days after birth, and showed signs of lung parenchymal damage as indicated by a respiratory index of more than 2.5. These were not babies that were 24 hours on a ventilator because of sepsis. They were on a ventilator because of lung problems. The intervention group received hydrocortisone in a cumulative dose of 72.5 milligrams per kilogram divided over a course of 22 days. So significantly higher than what was used and longer than what was used in the Primulog trial. The comparison group received placebo, and our primary outcome was death or BPD measured at 36 weeks post-menstrual age. We included 372 babies, and you can see here that the mean gestational age is a week lower than in the Primulog trial. And here you can see that almost 2/3 of the babies were below 26 weeks. So these were much sicker babies with a high risk of developing BPD. There was a rescue treatment in the placebo group or in the hydrocortisone group, somewhere between 28 and 57%. So these are the outcomes, the results of the StopPPD trial. And the first line, you can see the risk of death or BPD at 36 weeks, and we found no significant difference. If you look at the components, again, BPD at 36 weeks, no significant difference between hydrocortisone and the placebo group. Interestingly, and a bit unexpected, was that we did find a significant reduction in mortality at 36 weeks in favor of those babies that were treated with hydrocortisone with a number needed to treat of 12. I'm not sure really, we are not sure how to interpret this, but it is a really interesting finding. It's weakened a bit by the fact that this was not a primary outcome, but a secondary outcome. So you would classify this as an exploratory analysis, but still it's a really interesting finding. We also did a 2-year follow-up of those babies that were randomized to the StopPPD trial, and reassuringly, you can see that hydrocortisone, although not effective in reducing BPD, it also is not a risk factor for a neurodevelopmental impairments in those babies treated with hydrocortisone. What about short-term effects of hydrocortisone in this sick population? Well, there seems to be a short-term effect if you look at parameters that are indicative of lung function. This is the fraction of inspired oxygen in the first 7 days of treatment. And in white, you can see hydrocortisone treated babies, and in yellow, placebo. And you can see that using hydrocortisone gives you a significant reduction of FiO2 over time. And the same is also true for the mean airway pressure. So there seems to be a reduction in both these parameters, indicating an improved lung function. And this is also translated to, if you look at extubation, so on the y-axis, we have the proportion of infants failing extubation, and on the x-axis, the treatment over time. And it's clear indicated in white that babies treated with hydrocortisone are earlier off the ventilator compared to the babies that were in the placebo. So hydrocortisone does not affect BPD, but it does have an effect on short-term lung function, allowing babies to get off a ventilator. Finally, there's a second targeted trial done by the NICHD network. In this study, preterm infants less than 30 weeks, also on invasive ventilation, but now after 2 weeks of life, were randomized to hydrocortisone in a similar dose as with the Primaloc trial, so a low dose and a short dose of hydrocortisone. These infants are compared to babies treated with placebo, and their outcome in this trial is survival without BPD or neurodevelopmental impairments determined at 2 years corrected age. Unfortunately, there have been abstracts, but the study has not finished peer review as far as I know. So we need to wait the final results of this study and look if they are similar to what we have found in the StopPPD trial. So to conclude, I think dexamethasone reduces the risk of BPD, but is associated with long-term adverse effects, especially if you use it in a prophylactic way, so starting early after birth. I think that early low-dose hydrocortisone treatments may reduce death or BPD, but especially in high-risk infants, and as I showed you in the Primaloc trial. And hydrocortisone treatments, targeted treatments after the first week of life, improves short-term lung function, but it does not reduce the risk of BPD. There is a somewhat unexpected effect on mortality in favor of hydrocortisone, but it's unclear how we should interpret these results and how we should actually pursue this in future trials. That's it. I'd like to thank you for your attention.